people who were here last week. Can I just ask, who is iPhone 53? Some of this is interactive today, and we just want to make sure, see who we're chatting with. Silence. Okay. Well, iPhone 53, if you can.
Oh, there they are.
Hi,
Dr.
good to
Tan,
see
okay.
you. And it looks like you may be working clinically, so the chat is okay too. I understand that everybody here sometimes is multitasking. There we go. Thank you. Thank you, Dr. Lepong. Appreciate it. Okay. Hi, Jane. Welcome. I'm going to start sharing my screen. Hey, everybody. Okay, we're going to get started. Some of this today is interactive, and we're going to be using the chat and some polls. But please let me know if at any time you have questions, and we can stop to go over some of these concepts. So building off of what we talked about last week, we're going to be speaking a little bit more about BiPAP and our patients who come in short of breath and what we need to think about and what our immediate interventions are. Similarly to last week, we're going to start with a case, and then we will do a question, and we'll do a deep dive into some of our teaching points and concepts. So our first case is a 67-year-old man who's coming in with sudden onset of shortness of breath and has the vitals listed there. As we can see that they are tachycardic to 123, hypertensive to 230 over 115, tachypnic to 36, satting 82% on room air, and afebrile. Who can see the transcript? Okay, what information would you like to know? And if anyone can put their thoughts in the chat or feel free to speak up, either one is helpful. Give people a few more seconds.
Hey, Juliet, can I ask a quick clarification question?
Of course.
Do you mean like what do you want to know for history or like objective
Yeah,
data?
history
Okay.
or any physical exam findings. Oh no, go
Okay,
back.
I'm going to put some things in the chat.
Okay. Okay. So moving forward with our history for this patient, you get additional history from the wife, who notes that he's coming in with acute shortness of breath that's worsened over the past few hours. His wife says that he ran out of his medications a few days ago and went to sleep in the recliner this evening because he hasn't been able to lay flat in the bed, and woke up after a few hours complaining of shortness of breath and a cough, which is productive of frothy sputum. His wife additionally reports his shoes aren't fitting because his legs are more swollen than usual, and he doesn't have any chest pain or any additional symptoms, including infectious symptoms. Sorry, guys, my computer's slow today. Additional past history is that he has a history of hypertension, he has diabetes, he has a history of CHF, but he does not know his last ejection fraction. His notable medications are furosemide, metformin. He is on a statin and is on amlodipine, but he does not know his home dose. He does not have any positive social history. Our physical exam, he's ill appearing. He's in severe respiratory distress and speaking only in short phrases. He has a notable JVD up to his mandible. As we said earlier, he's tachycardic, but he has a regular rhythm. He has diffuse crackles in his lungs bilaterally with poor air movement and significantly increased work of breathing. And he has 1+ pitting edema bilaterally and has intact pedal pulses and cool extremities. What are potential differential diagnoses?
Written about horsepower,
Mm-hmm.
pneumonia, because
Yep.
he has a lot of sputum coughing. Uh, because he has the edema. Maybe we need to rule out the pulmonary embolism.
Okay. That's a good thought. So I heard pneumonia, pulmonary embolism, pulmonary edema. Was there anything else that we needed to think about? I think the only other one that I would add on here is possibly cardiogenic shock, just with some cool lower extremities and some bilateral extremity pedal edema. So interventions, are there any treatments, labs, or imaging that you would like to order right now? Dr. Hatu, do you mind also helping with this one? Yeah, thank you.
Intervention now, I think apply the monitor for follow up the vital sign, continue oxygen, and we repair the IV, maybe give them some medication.
Okay.
The lab we order the EKG because we need to rule out we need to find why he has the respiratory problem. Maybe the ACS, troponin, liver function, kidney function, BNB, it means anti-proBNP. Imagine I order the chest X-ray, ultrasound. I think, yeah.
Perfect. I like those. And then it sounded like you were putting him on the monitor and we were getting a repeat set of vitals. And you mentioned placing the IV and possibly starting some medications. Are there any medications that you would want to start now? Or would you want to wait for more information?
I think now the stable is a little bit stable. That reason I think I need to more know more information.
Okay.
But you don't give the vital sign already, right?
Yeah, we can go back to it. He was tachycardic with a heart rate in the 120s. He was pretty hypertensive. Yeah.
I will order the nitroglycerin for you.
Perfect. Okay. Good. Okay. Otherwise, I agree with you. So let's see if this will let me do this today. If not, hopefully you can see that our ultrasound, I agree with Dr. Hotu that we would get an ultrasound, which we went over this a little bit last week. What kind of imaging findings are we seeing here with this ultrasound? You guys can take a minute and I will try to open this up and see if you can still see it. Shakira, can you still see my screen when I do this?
I can. It's not in the presenter mode, but I can see it really clearly.
Okay.
The video's not running though, if that's what you're trying to do.
Okay. Yeah, I was going to open up a second. I think it's going to need for me to go into the other one. Sorry, guys.
Use your imagination.
Use your imagination for what it looks like. Okay. Well, this seems to not be working today. I'm sorry, everybody. So that, like we talked about last week, what is this indicative of? This chest X-ray also looks like trash.
I see the line running from the pleural line throughout the screen, and on the right side, I can see a dilated left heart chamber.
Yep. I agree with you, and I'm sorry that the video clips are not more informative today. But yes, and then as confirmed by our POCUS, our chest X-ray shows this. Dr. Nonlai, would you like to comment on this chest X-ray? And if you feel like it is similar to what you were expecting because of your ultrasound findings?
I'm sorry, I'm in the middle
No,
of my shift, so
no, that's okay.
just
Oh, I'm
let
sorry. Well,
me
thank you for
find.
joining us. I got you on that one. It's
No, no,
okay.
no. Let me find somewhere quiet.
No, Dr. Nunley, we appreciate your multitasking today. So I would say that I agree that the ultrasound showed us some B lines concerning for pulmonary edema, which we found on our physical exam with the diffuse crackles. And I agree with Dr. Ho too that I would be giving this patient nitroglycerin when they came in. And this is very similar to what Dr. Hotu was asking us to order. So we have a BMP showing us our renal function, which isn't terrible. I would have to see what his prior looks like. The liver function tests aren't showing any diffuse evidence of end organ damage at this point. There's no signs of infection with any leukocytosis. And the urinalysis has negative protein, which makes me think that that this may be the patient's baseline kidney function. So in addition to the nitroglycerin, can someone talk to me about what route, so either by mouth, through an IV, through a drip, or as a paste, you would like to provide the nitroglycerin, and if there are any other medications that you could give at the same time?
We can give him some diuretics like furosemide, as well as then in combined with nitroglycerin and also morphine to help with his agitation. And if we have the evidence of low EF, we can give him some inotropes like dobutamine.
Yeah, I think that is a good idea. I think that I would personally wait a little bit longer before giving him dobutamine to see how he responds to your interventions. Sometimes here, I know in my emergency department, it takes a while to get the nitroglycerin drip ready. So I will often give people sublingual tabs, which we use for our cardiac patients underneath the tongue while we're getting the pump set up or waiting for it to come from pharmacy. Some people have nitro paste that they prefer to use and slather it on the chest. I personally, during training, didn't prefer this method because sometimes people forget that it is there. And if the patient overcompensates and you have a hypotensive patient, people forget that you can wipe it off. So we're going to talk about this in a moment, but the starting drip for nitroglycerin is kind of up for debate. There has been some recent literature that starting at a higher dose can help your patients turn around faster and decrease the length of time that they need to be on the drip, or the amount of time they require BiPAP, if that is available at your site. Dr. Nonley stated that furosemide, a diuretic, usually giving more than what they are on at home. What I was taught is to wait a little bit until the nitroglycerin takes hold, because with furosemide, sometimes you can get some rebound hypertension, which can make your pulmonary edema worse. An additional intervention where we kind of spoke about it last week in a patient who here is hypoxic and having tachypnea due to the significant amount of fluid in their lungs, I would think about initiating BiPAP if that is available to you. Obviously, if you don't have BiPAP, and the next line would be intubation, if you're able to do your medical interventions first so you don't have to intubate the patient, that would also be preferred. If you're going to start BiPAP, the recommendation is I start 10/5 and FiO2 of 100% and down titrate it, and kind of see how they do and hopefully try to get their work of breathing under control. Additionally, once you've done these temporizing measures, you can decrease the afterload with your ACE inhibitors. If you have captopril or enalapril, you can give either of those to help offloading the strain on the heart. So, yes.
Can you back to your slide?
Yeah, of course.
I just asked about your experience about the furosemide because so many cardiologists recommend us give the furosemide for the for the heart failure, pulmonary edema. But I think we just give it when we think about the patient have the fluid overload.
Sure.
But some patients have the pulmonary edema, no have the fluid overload, and we need to make sure the perfusion, enough perfusion with the kidney when we need the furosemide. That's the reason you can share your experience about why you know the patient have the fluid overload.
For this one, why I believe the patient has fluid overload? Sure. So if we look back at what the physical exam showed, that there was bilateral extremity pitting edema, and we looked at the lab results, and I did not see any evidence of that being due to hepatic congestion or a nephrotic syndrome. And the patient at their baseline is on a diuretic. And then on top of that, the ultrasound and the chest x-ray showed me, like you said, the pulmonary edema. But I am concluding and making a guess that this is most likely due to the heart function and his hypertension. Did that answer your question, or was the question more about using furosemide slightly later in timing?
Okay, thank you.
Okay. So moving on to our first question. I know it says number 5, but our first question, which ultrasound finding is consistent with pulmonary edema?
Okay, so Juliet, I'm going to launch this as a poll. So everyone, you're going to get a quiz that's going to pop up, and that way you can all answer it. Give me just a second. Here we go. Can you guys see that poll pop up? Okay, great. Let's get some answers here.
Oh, it's in a different order.
You guys are too good. Okay, we'll give it just another second to see if anyone adds. Okay, here's the result. Can you guys see that? Looks like everyone who responded chose B line.
Perfect. Good job, everybody. So this is just kind of bringing us back compared to A lines from last week. As we can see in this top picture, you have the horizontal areas of hyperechoic shadow, whereas the B lines are showing subpleural interstitial edema, and you are getting the comet tail streaking down from the pleural line down to the bottom of the screen. We should just talk real quickly that not all B lines demonstrate pulmonary edema due to fluid overload. Anything with thickening of the interlobule septae that increases the lung density can also give you some evidence of B lines, and it's bringing into it your clinical gestalt where you can help make that next medical decision. So you can also see this sometimes in pulmonary fibrosis, in ARDS, early pneumonia in some cases, and with pulmonary contusions that you see in trauma. Again, going back from last week, where we spoke a little bit about BiPAP, and some of you shared that you use early BiPAP for your COPD exacerbations to help with your increased work of breathing. We talked about the indications, which are severe tachypnea, any signs of hypercapnia that you get on your ABG. Reasons we would not do it is it sounded like at some institutions that if you don't have it, you go straight to intubation. If your patient is vomiting, that would be a reason that they are not protecting their airway, and you would go straight to intubating them. Or if they're having copious secretions similarly to vomiting, and they're having difficulty with managing those secretions, you would go straight to intubating and not go through BiPAP. I found this image very nice and informative between type 1 and type 2 respiratory failures. So today we're talking about type 1 respiratory failure, where you can't oxygenate because there is fluid that is surrounding those alveoli and impairing the surface area for the oxygen exchange. So whereas last week you couldn't ventilate because there was hypoventilation and there was too much CO2 retention. Alrighty, let's go to the next one. Continued, just reiterating what we just spoke about, that BiPAP in pulmonary edema or in congestive heart failure, starting at 10/5 for your inspiratory to expiratory ratio, and then you can increase it up. Whereas in COPD exacerbations, you want to mostly increase your IPAP as compared to leaving your EPAP fairly similarly to increase that gap. With CHF, you can titrate them up together to help achieve your airway pressure. If you don't have BiPAP, you can use CPAP alone to kind of help drive that fluid back out of the lungs and help your oxygenation. Just as a note, if you are seeing low tidal volumes, if your machine allows you to see them, this could be a sign of inadequate ventilation or that your patient is tiring out and is something that you need to go back in and assess and see if at that point you need to change your medical management, either with your nitro drip or if you need to move towards intubation. Okay, so as I touched on before, this was a paper that came out last year that caused some stir while I was doing training, opting for high-dose nitroglycerin infusions for those that have pulmonary edema due to the sympathetic crash or hypertensive emergency-driven pulmonary edema. So they recommended an infusion rate starting at 200 micrograms a minute, initially with sublingual, and then going over to a bolus dosing with that prior to putting them on a drip. They found that this decreased the rates of intubation, acute kidney injury, and hypotension when they monitored them again at 48 hours. At the same time, as we spoke about with our medication management, they simultaneously received treatment with an ACE inhibitor or an ARB. Just as a question for my colleagues over there, are you using a high initiation rate for your nitroglycerin, or are you starting lower at around 50 or 100?
We usually start with low dose first, and then we feel different.
Okay. Yeah. Traditionally, that is what I started doing my first year, but since this paper came out, I've started people at around 150. I'm not as confident in doing 200 right off the bat, even though knowing we give them about 400 micrograms when we give a sublingual nitro. And I've had pretty good results and have been able to get people off of BiPAP a few times, which has been nice. Just a quick comment. I know BNP is used a lot in my emergency department out here. It's kind of knowing the limits of your lab test and which one you have. We have the NT Pro BNP, which is released by the cells and then cleaved into the active BNP. The half-life of these two are different. The half-life of normal BNP is much shorter. And if any of your patients are on a medication named Entresto for heart failure, you can't use this to help determine the level of fluid overload or how their cardiac function is doing. However, BNP is elevated in a number of conditions, including any signs of right heart strain, pulmonary embolus, atrial fibrillation, and some chronic respiratory diseases, and in sepsis. In many of the studies that I read in researching the utility of BNP, it's also increases with decreasing kidney function. So an increased creatinine of greater than 2 on our scale out here shows an elevated BNP and didn't have great relatability. When taken in conjunction with ultrasound, ultrasound had a greater ability of the physicians to be able to tell if they had fluid overload when compared to the number of BNP. Additionally, BNP just was used to decrease the cost on the inpatient side and didn't significantly decrease the emergency department cost or management when taken into consideration of the entire picture of the patient. There was a slight decrease in the length of stay if a physician got a BNP while in the emergency department, as it seems it helps our cardiac and inpatient colleagues help titrate their inpatient medications and then transition them to outside. Of note, this table down here in the bottom shows the cutoff values for a BNP versus the NT-Pro BNP. If any of these are less than 100, the likelihood of heart failure is very low. Whereas if it's greater than 500, I realize the NT-Pro BNP says greater than 450. I still use greater than 500 for both of these values. Then the likelihood that they have heart failure is more significant. You can use this as a trend to see where they were from the last time your patient came in with a heart failure exacerbation to see if they are possibly more or less fluid overloaded. However, they don't continue to trend these well in inpatient. Okay. Any questions about pulmonary edema or any of those slides before we move on to our second case? Okay. So we'll move on. This second case is about a 45-year-old female who comes in with known pulmonary arterial hypertension and is here with shortness of breath. Our heart rate is 111. Our blood pressure is 90/58, respiratory rate of 26. SpO2 on room air is 87%. A quick doorway assessment shows your patient is short of breath with increased work of breathing. Going by the ABCs of a short assessment in a patient who might be an extremis, the airway is she's speaking in short sentences. Breathing, she's tachypnic, but when you go and listen, she is clear to auscultation. The circulation, she has cool extremities with 1+ distal pulses. Similar to the last poll, is there any additional information you would like to know, such as home medications, recent hospitalizations, or any additional information from a family member? So let's go move forward with possible differential diagnosis. If you're able to, could you please put them in the chat or speak up and turn off your microphone?
When I ask about the duration of the symptom of this patient,
we haven't gotten to that yet. You just know that they're short of breath. We haven't had the rest of the information yet.
Certainly on several hours, several days. The duration of the symptom.
I know. We'll get to it on the next slide. It's a couple of days.
Okay. Mm-hmm. It's about pulmonary edema, pneumonia, less likely pneumonia because the lung side clear, and PE.
Okay, great.
Yeah.
So I agree. PE, COPD, sometimes you can be tricked in patients who have silent chest, where if the degree of their COPD exacerbation is so great that they are no longer wheezing and not having great air movement. This could be a heart failure exacerbation with pulmonary edema, although we would expect to hear crackles as we did in our last patient. This could be due to cardiac disease, either a pericardial effusion causing some tamponade, heart failure, causing a cardiogenic shock picture, cardiomyopathy. Could be due to cirrhosis with fluid overload state. Could be due to nephrotic syndrome within fluid overload state, or it could be due to pulmonary hypertension. And because we asked you to read about pulmonary arterial hypertension, I'm guessing that that's what it's going to be today. So going forward, this is a 45-year-old female who's coming in with 3 days of worsening shortness of breath and weight gain. She has been taking her furosemide as prescribed, but has noticed worsening lower leg edema and decreased urination. She reports shortness of breath with just walking to the bathroom. Otherwise, her review of systems is negative and no recent illness symptoms. Besides her history of idiopathic pulmonary arterial hypertension, she has no social history risk factors and has no allergies. Our physical exam for her, she is alert, but in moderate respiratory distress. You notice that she has an epoprostenol pump that seems to be running. She has JVD also up to the angle of her mandible. She is tachycardic, as we saw on her inset take of vitals. She is tachypnic, but otherwise her lungs are clear. On the extremities, you see she has a PICC line where the insertion site is clean. She has bilateral 3+ pitting pedal edema and 1+ distal pulses, and her skin is cool with delayed cap refill. So knowing that, what image would you like? What kind of imaging would you like to order?
Maybe chest X-ray and then focus.
Yeah. Okay. Yeah. Chest X-ray, I think, is a good start. Are there any specific labs or other interventions you would like to order? I think it's very similar to what Dr. Hotu said for our first patient, where we are looking for cardiac etiologies, lung etiologies. So in this patient, I would get a troponin in addition to our baseline labs of renal function, liver function, getting a urine if they're able to make any. And in this patient, I would likely also still get a BNP, even though we just discussed the questionable utility of getting that test. And immediate interventions, and someone who is borderline hypotensive, who's tachycardic with cool extremities and with a history of pulmonary arterial hypertension. Are there any immediate interventions that anyone would do? You're also allowed to wait for more information, which is okay. Okay, I agree.
I will immediately want to start to idealize peripherally or one to central.
Yeah, I agree. I think getting your access early is a great idea, especially in someone who looks to be in a, if not already in a shock state, in a very near shock state, so you don't have difficulties later. So someone who I would get an EKG on earlier, if you had asked for an EKG, it shows tachycardia with right heart strain. It doesn't show any signs of ischemia. Otherwise, let's move forward. So if you pull out your ultrasound machine, this is what you see. Can anyone comment on the images that we have here?
So, from the ultrasound, I can see a dilated right heart chamber as well as dilated IVC. And it looks like the right ventricle is pushing the left.
I agree. And Dr. Vomin-Fook, it looks like you were going to say something. What does this ultrasound make you concerned about?
I'm concerned about PE since this is related treatment and maybe some surprises on her previous pulmonary arterial hypertension. But in this case, we must rule out PE.
I agree with you. If someone came in and we did not know that they had pulmonary arterial hypertension, this ultrasound would make me concerned for APE. It's hard to see on this ultrasound if there is any signs of remodeling of the right ventricle, which you can see if there is chronic right heart strain. But I agree, we are definitely seeing right heart strain with the dilated right ventricle, the dilated right atrium. There looks like there is some septal bowing, and we are also seeing McConnell's sign as well as the D sign in the parasternal short. And I agree with Dr. Nanle is that I'm also seeing a plethoric IVC concerning for congestion. If we had images, we could see what their EF was and see if there was concern for primary cardiogenic shock. So, as we just stated, the apical forechamber has dilation of both chambers on the right side. They're calling that there is some free wall thickening of the right ventricle, which is concerning for chronic right ventricular heart strain. We're seeing the bowing of the interventricular septum, and we are seeing a plethoric IVC. And if we watch the video, there would be less than 50% collapse concerning for fluid overload. Someone asked for a chest x-ray, and as compared with our first chest x-ray, I am not seeing signs of pulmonary edema or large pleural effusions to account for the tachypnea of this patient. So we talked about the chest x-ray, we talked about the ultrasound. The next step, I believe that the concern would be high enough for a potential pulmonary embolism that we would go get a CTA of the chest. The CTA of the chest in this patient shows a dilated pulmonary trunk and pulmonary arteries that's consistent with pulmonary arterial hypertension and doesn't show any signs of pulmonary embolus on here. Interventions that you want to do for anyone who comes in with a continuous pump is to check that the pump is functioning properly, check the PICC line, that there are no signs of infection at the site of insertion, and that it is still able to flow freely. For patients with pulmonary arterial hypertension, you want to continue their home infusions, as these medications have a very short half-life, and if they are precipitated into a withdrawal or have them stopped, they can decompensate very quickly. If you don't have the medication that patient has in the pump, you can consider using inhaled nitric oxide, any prostacyclins that may be in your department. You can use them inhaled or through the IV. You can also use the PDE5 inhibitors that are often, that the patients are often on. Most of our patients out here are usually on sildenafil. I've seen very few on tadalafil. Similarly with these, if you don't have it in an oral form, you can try to get it in the inhaled form. Although I don't know if you don't have it in PO form that you're going to have it in the inhaled form, but should show me what's going on. The third line is if you have it in your department, you can use a long-acting prostanoid to prostanil. We went over the labs that we would get, including the troponin, the BNP. We also have to remember to keep a broad differential in someone who is in a potentially shock state. So the tachycardia and the borderline hypotension would make us think that we still need to get blood cultures and likely start antibiotics soon, even if we think that this is a primarily cardiogenic or pulmonary arterial hypertension etiology, meaning we would also get a urine if they are able to make any and send off for a urine culture and to get an ABG. So we sent all of our things off, and our results are notable for a slightly elevated potassium, and slightly elevated BNP, an elevated troponin, an elevated lactate, and a ABG with a pH of 7.32, a CO2 of 60, a oxygen of 38, and a bicarb of 21. So we'll go back. Where is this patient being admitted to? What service? Do we think that this patient is stable for the floor? Do we think maybe this patient needs to go to a regular ICU or the MICU? If your hospital has a dedicated cardiac ICU or surgical ICU, where do you think that this patient would get the best care due to her symptoms today?
ICU.
ICU, yeah. Yeah, I saw Dr. Vominfa also mouth ICU and say no to the floor. I agree. So you call your friendly pulmonologist and say that we have concern for worsening pulmonary arterial hypertension from fluid overload. We had a echo that showed right heart failure and concern for cardiogenic shock because of cool extremities. Our consultant said that they would like us to start early pressors, and they recommended starting milrinone and said, no, please don't give this patient any fluids. They already have enough. So our diagnosis here is cardiogenic shock due to right heart failure. And our secondary diagnosis is that it looks like she also has a NSTEMI due to that elevated troponin, showing increased signs of right heart strain. So this would be a type 2 NSTEMI, and pulmonary arterial hypertension, and she had a mild AKI when we looked at the renal function. So a review. The interventions that you want to do when this patient comes in is that you want to check that their pumps are functioning. As we talked about, the half-life of these medications for pulmonary hypertension patients are very short, and they can crump very quickly. The history of severe pulmonary arterial hypertension makes taking care of these patients very challenging. Shakira and I were talking about it before we jumped on this call, that they are a very fine balancing act of fluids or starting pressors very early, because typically when you have someone who is coming in who is hypotensive and tachycardia, and you have a concern for possible sepsis or shock, the knee-jerk reaction is to give them a bolus of about 1 liter of fluid. But if you give a patient who is this fluid overloaded with a poor forward pulmonary circulation, that much fluid, you're going to worsen their condition and they will decompensate while in your department. So you can try a small fluid challenge. In these patients, I usually do 250 mils and see if that changes their blood pressure at all, and see if that changes their work of breathing, or if that changes their clinical picture at all, while at the same time reaching for vasopressors. On your ultrasound, we talked about that you're going to see signs of right heart strain, but just knowing that that may be their baseline. And while we always are taught to think about pulmonary embolus, which is something we have to rule out here, we are going to see signs of remodeling of the right heart if that's something that is chronic instead of acute. You would also see signs of the pulmonary arterial hypertension on the CTA, as we discussed. You're also going to see that right side of the heart being enlarged, and you can also see some septal bowing and sometimes some regurgitation back into the pulmonary artery. Consult your friends in pulmonology early so that they can be dispositioned to either an ICU or possibly a cardiac ICU for a pulmonary arterial catheter placement, which can help titrate the fluid status of this patient a little bit more finely than they are sometimes able to do in the ICU. So if that is something your cardiology service places, or if you're a pulmonologist in the ICU places, that is just institutionally dependent. So our overall goals in pulmonary hypertension are to try to reverse the underlying cause that caused them to come see you. So whatever insult caused this acute decompensation. Widely, you're trying to decrease the right ventricular afterload and from the increased peripheral venous resistance. In pulmonary arterial hypertension, you get something called the lethal triad, meaning that they are going to crump soon. You get a combination of acidosis from poor perfusion. You get hypercarbia because they're not ventilating as well, as well as you get a mixture of hypoxia. Because they can sometimes present as a mixed pulmonary edema and COPD picture, your goal is above 90 to 92%, and you're trying to maximize and correct the acidosis, the hypercarbia, and the hypoxia earlier, which is easier said than done. Some of these patients, they come in with tachycardia and are more prone to dysrhythmias, and they may be on a beta blocker at their baseline. But when they are in a pulmonary hypertensive crisis, you want to avoid giving them beta blockers or calcium channel blockers, because this can blunt the cardiac response and decrease your cardiac output and can cause hypotension. So if your patient has a history of pulmonary hypertension and they come in atrial fibrillation or a flutter, you're going to want to try to cardiovert them instead of reaching for your beta blocker or your calcium channel blocker to correct and rate control. Additionally, you're going to try to support the systolic function and the perfusion of the right ventricle to avoid hypotension and ischemia. So that means reaching for your pressors early. Here in the United States, our first line is usually norepinephrine if they're hypotensive. There is literature suggesting that you can reach for dobutamine if they are not hypotensive, or milrinone. For dobutamine, you do have to be careful using it as a single agent because it can cause tachycardia and it can decrease your systemic vascular resistance, and you can get some hypotension with it, which is what you're trying to avoid. But there is no perfect one pressor to use for these patients, unfortunately. You have to often use multiple vasopressors to get the perfect balance where you're balancing the pulmonary vascular resistance with the systemic vascular resistance with the blood pressure. So that's why we try to get some blood pressure support with norepinephrine early and then add on a second agent like dobutamine. If you have milrinone, often that one's a little bit better tolerated with your blood pressure support. As a note, please avoid phenylephrine. It worsens your RV function. I feel like I only really use phenylephrine if someone has severe aortic stenosis or if you really need it as a push dose. Additionally, if you have nitric oxide, you can use the inhaled version to help promote vascular smooth muscle relaxation. It's going right down into the alveoli and helping to relax those muscles so that you can have better oxygenation. Additionally, continuing the prostacyclins that they're on, either inhaled or IV. I've been told multiple times that when you have someone like this coming into your department, please continue their home medications. If they can't take them by mouth, please try to find the alternative in the IV and keeping them on that schedule so that you can help address the other systems that are needing to be balanced. And finally, you're trying to optimize the right ventricular preload without overloading them. So like we talked about, very small fluid boluses, so 150, 250 at a time. And I know we just spoke about using BiPAP and early non-invasive positive pressure ventilation. This is a patient where you're going to try to not intubate them or to give them BiPAP if possible. You're going to try to support their breathing with high flow if you need to, first line instead of BiPAP, and using your early vasopressors and any inhaled or IV medications to help decrease the pulmonary arterial resistance. Because you can get, this is a nice little depiction I found of the fun overcircling effects of the increased right ventricular overload. So your underlying issue is that your right ventricle is overloaded. So that causes bulging of your septum into the left ventricle. And because your left ventricle and your right ventricle have interventricular dependence, when that left ventricle is now decreased in size, you have decreased cardiac output. And because of that, then you get decreased perfusion back to the right ventricle because you have a decreased amount of blood circulating through your coronary arteries and systemically. This increased pressure and volume by the right ventricle can cause worsening tricuspid valve regurgitation. As you think about it, you have increased pressure and the valves of the ventricle keep getting pushed further and further apart. And when that happens, you can get decreased cardiac output and causing end organ perfusion damage. The chronic right ventricle compensation can only compensate so far. And after a certain amount of distension, you can still get ventricular failure, and they can present to you like this. I know this is a lot of information about this. I'm sorry, guys. There are 5 groups for pulmonary arterial hypertension and kind of how they're treated. The first one has, idiopathic in there, connective tissue diseases, some infections that are, you have the hypertension due to the lung parenchyma remodeling. The second group is hypertension due to left heart disease. Depending on which literature you look at, in the United States, the number 1 cause of pulmonary arterial hypertension is either due to group 2 or group 3. So either left heart failure and disease or COPD. With group 2, includes both preserved ejection fraction heart failure and reduced ejection fraction heart failure. And the treatment is aimed at using diuretics to decrease the overall fluid strain on the left heart. The third group is lung disease and hypoxemia, which is our COPD patients. I haven't seen very many patients with pulmonary arterial hypertension due to COPD. The ones I've seen have been more due to left heart failure. But your patients with COPD, the chronic hypoxemia with inadequate oxygenation causes the pulmonary arterioles to constrict over time, and you get decreased pulmonary vascular beds, which causes pulmonary hypertension. The fourth group is CTEPH, so your chronic PEs that are causing increased resistance because the blood can't flow normally throughout the lung. And then group 5 is, again, idiopathic. You can also get some reconstructive diseases like scleroderma or congenital heart diseases as well. I know that was a lot of information. Let's see if anybody, I'll start off with an easy question. What are common symptoms of pulmonary arterial hypertension? I think Shakira has a poll.
All right, let me know if anyone can't see it, but let's get a few more answers in there and then I'll end the poll.
Okay, cool. Yeah, so the person who picked dyspnea on exertion wasn't wrong. It's just that there are a few other symptoms where pulmonary arterial hypertension can present. You get decreased exercise tolerance. You get dyspnea on exertion. You can think about these as a heart failure exacerbation patients. You get syncope or pre-syncope, and then fluid overload. So I think about pulmonary arterial hypertension is that globally the patient looks like they're in heart failure exacerbation except for their lungs. Everywhere else seems to be fluid overloaded. Just wanted to give a side-by-side picture of the heart. And the left side of the screen is a normal heart versus heart in pulmonary arterial hypertension on the right. As we stated earlier, you see the signs of chronic right-sided failure with RV and RA remodeling. And you can see the D sign as well as McConnell sign on here. Worldwide, the most common cause of pulmonary arterial hypertension is schistosomiasis, which I found very interesting. This is just reiterating that the right ventricle is thin, and when it becomes fluid overloaded, it can't accommodate to changes in volume or pressure, as well as the left ventricle. And therefore, you can get that pressure upon the septum, which then bows into the left ventricle. But this also means that they have limited contractile reserve. So any change in their overall picture, they're very prone to decompensating. So treatment, like we said, early vasopressors and inotropes. I believe someone talked earlier about starting dobutamine pretty early to help with the forward flow on our last patient. We're trying to avoid intubation if possible. Although we stated that hypoxemia and hypercapnia can worsen the right-sided heart function, but when you have that positive pressure on there, you are, sorry guys, you're decreasing the preload to the right side of the heart, as well as increasing the afterload, which doesn't help with forward flow in this case. And additionally, if you have them, using your pulmonary vasodilators, so nitric oxide, sildenafil, tadalafil, epoprostenol. So the diagnosis of pulmonary hypertension is traditionally made via right heart cath, which is why sometimes these patients can be admitted to your cardiac service. You can also see it on a normal echo, although that is outside of the scope of how well I use my echo ultrasound skills. If you are measuring the right ventricular systolic pressure via your echo, it's going to be greater than 35. As a note, a BNP greater than 1,500 is associated with increased mortality. So I know that we can get a BNP to kind of track where our patients are, but a high BNP correlates with a higher mortality and usually shows a higher likelihood of them being fluid overloaded. As we spoke about, they have little physiologic reserve. So any type of illness, any change in their volume status, any arrhythmias, or changes to their ventilation can precipitate an acute on chronic failure. As this is my last slide, guys, so we're almost there. So using your vasopressors early. As we spoke about earlier, there is no one perfect vasopressor to use in these patients. Norepinephrine is the first line. You have to be careful because the high doses can worsen pulmonary vascular constriction and resistance due to the alpha stimulation. Dobutamine, they still say is first line, if not yet hypotensive. You do have to be careful with higher doses because that can cause some tachycardia and some decreased systemic vascular resistance, leading to hypotension. You can use milrinone or epinephrine as a second line if they're not yet hypotensive. The milrinone helps reduce the pulmonary vascular resistance and helps decrease pulmonary arterial pressures. So if you have milrinone, I think that would be even though the literature says first line dobutamine, I feel like I would lean towards milrinone instead of dobutamine. Okay, guys, last question. All of the following are drugs that can be used to treat pulmonary hypertension, except which medication? Either put it in the chat or we can go over it in a minute.
Julia, I have a poll ready for it too.
Okay, if you want to put the poll, that works.
The last poll, we have to do it. Okay, here it is. All right, here are the results.
Okay. So a couple of people were correct that procainamide is a medication we don't want to give our pulmonary arterial hypertension. Remember, we're avoiding beta blockers and calcium channel blockers, even if they have arrhythmias. But we do want to continue them on their sildenafils, their PDE5 inhibitors, bocetan and pimobendan. Oh my goodness. choice D, which are likely home medications that can also be used for pulmonary arterial hypertension. Although all I was seeing for the last one is use in animals, unfortunately. That's all. I know that was a very informationally heavy session. Does anybody have any questions before we end our session for this week? Okay.
Thank you for tackling this giant topic, Julie.
Yeah, sorry guys. Pulmonary hypertension is a beast. So this is our summary. Heart failure exacerbation, use your POCUS early in both of these conditions. When your patients are stable, you can just give them diuretics like the furosemide. If they're unstable, give them your nitroglycerin first, your BiPAP, your diuretics, and your ACE inhibitors. Your pulmonary hypertension, always be okay calling for help. Start your vasopressors early and be careful with your fluids. Okay. All right, everybody. Thank you. I appreciate your time. As a heads up for next week, we're going to talk about pulmonary embolism and some decision-making tools. We're still looking for anybody who plans to be here on December, what day is that, Shakira?
It is, let's see.
December 28th?
27th. 27th.
Or 27th or 28th. So December 28th for our colleagues in Vietnam to help give a case presentation if you are able.
Yeah, and send Juliet and I an email. We'll help you. If you don't have a case, we can give you one and kind of walk you through it. And everyone's going to have to do this year. So if you volunteer early and get it out of the way, that's a good sign. If not, we'll go ahead and assign someone or have Dr. Dai assign someone. So better for everyone if you send us an email and if you're free.
I have a case, but I've been very busy with my work, so I'm still doing the PowerPoint for next week.
Okay. Yeah, that would be great. We'd love to hear your case. But we understand. I feel like every time we've had these sessions, you're on shift and multitasking. So let us know if you want help with somebody else to present a case together, if that might be easier to split the workload.
It's fine because I just right before this section, I have to interview someone. So right after that, I have to run for somewhere very quiet.
That's understandable. Okay, please go take care of your patients. We appreciate your time.
Okay, thanks everyone. And Julia, if you want to stay on for just a minute, we can always chat about next week. But I think
sure
we're all good with the session for everyone. Thank you guys for joining.
Okay, thank you. See you next week.